Good morning, everybody. Good. Good morning. Welcome to Cardiology Grand Rounds. It's my pleasure to introduce one of our colleagues from vascular surgery, Sara Zettervall. She is an assistant professor of surgery here at the University of Washington. Her expertise is in complex aortic disease. She has a really interesting training pathway. She did her surgery training at George Washington University, and then her advanced training in aortic disease at Beth Israel Deaconess. But while she was visiting for probably a number of years in Boston, she was on the T32 at Harvard and did both basic science with mouse models looking at calcification and atherosclerosis in peripheral vascular diseases, as well as outcomes research, where she's continued to have a very successful career working with large databases and also advancing her expertise in customized aortic devices, which I think we're going to hear a little bit about today. So Sara, thanks for joining us, and it's our pleasure to have you here.
Thank you so much, and thanks for the invitation to be here. So I think I've met a number of you. Obviously, our patient populations overlap tremendously, so it's great to meet so many of you in person as well. So here are my disclosures. Much of them is kind of related to what I'm talking about today, which is complex aortic disease and device trials. So I think to start, kind of the big question is, what exactly am I referring to when I talk about complex aortic disease? It's a very commonly used term, but it's kind of catch-all that's used in the literature, but not clearly defined. So kind of in my mind, when we're talking about these patients, really we're encompassing all the patients who can't be treated with just a regular EVAR or a regular isolated ascending repair. So the disease of basically the entire rest of the aorta. But even when we talk about this patient population, it kind of can be separated down into like the simple complex patients and the really complex patients. So by the simplest patients, I talk about kind of juxtarenal aneurysm. So still the aneurysm is below the level of the renal arteries, but it can kind of go up more proximally all the way up to just below the subclavian artery. Once we start getting dilation that gets near the arch, it becomes even more challenging. And so those are kind of a little bit more complex. But I think the most difficult patients for us to treat, which requires a ton of collaboration and a lot of what I'm going to talk about today, are those patients who have aortic disease that begins in the ascending, or those who have disease of the valve as well, and then kind of carries down. And the reason for that is it really limits our ability to clamp the aorta or to put stent grafts in kind of with what we have today with current technology. And I think the exciting thing is this is all a moving target and changing really rapidly, but still they remain really challenging patients to treat. So I thought I'd start with kind of an example of a case that we've taken care of here over the last 2 years. Let's see if this will play. So this is a gentleman who was referred over to me in clinic somewhat urgently by his cardiologist. He lives on the Canadian border. He's 58, so fairly young. As you'll see here, he has an 8.6 centimeter abdominal aortic aneurysm. He also has a 5.6 centimeter aortic root. So he has kind of two disease process. You see here, they did an EVAR in him in the past with the iliac branch devices, which is a great device to kind of keep patency of your internal iliac arteries. But clearly has no seal at the top, and he has now residual flow with a rapidly expanding aneurysm, as well as aortic disease that begins essentially at the valve. In terms of his medical history, this kind of complicates him. Even though he's young, he is a gentleman who's obese, has COPD, diabetes, and peripheral arterial disease. And I say with that, clearly he doesn't have a diagnosis of coronary artery disease, but anytime you see this disease constellation, we kind of have to assume that is there. But like many of our patients, he doesn't have particularly well-established medical care, nor a care team. In terms of his functional status, he was able to walk a block or two, but was really limited by shortness of breath. I think the other really interesting point in this gentleman is his dad died of an MI at age 42, so quite young. He's otherwise a former smoker, but still working and kind of fairly functional. So before we kind of get into how do we even start to tackle a patient like this, I think it's kind of important to set the stage. So when we talk about these complex aortic disease patients, historically management was always open repair. There are 4 surgeons who kind of are credited as kind of inventing this. It's debatable, I think, who actually did the first one. It was kind of all being done around the same period, both in the UK and the US. But I think there's little question that Dr. Crawford in Texas really kind of made this operation more robust. And between the 1950s and 1984, he completed 500 repairs of the open thoracoabdominal aneurysm approach, which is really profound. And honestly, even in this day and age, these numbers are not matched by many people. But that being said, even though this operation has been around for quite a while, the morbidity and mortality of an open repair of the thoracoabdominal aneurysm is actually exceptionally high. When you look at the textbooks, they actually talk about how this is arguably the most morbid operation that is done in any specialty. And unfortunately, despite huge advances in medical care and ICU management and anesthesia, and surgical technology, this remains really morbid. This is a study from the National Inpatient Sample, so actually is really reflective of what's happening in the real world. It's not just a single center experience, from 1998 into 2011. And it looked at hospital volume to try to account for all these things. And what you see is even at the highest volume centers in the country, and those are centers doing more than 12 a year, which is still not a huge number, but there's very few centers doing that. The mortality in hospital is 15%. For low volume centers, this is about 1 in 4 patients who don't survive hospitalization. So this is enormous mortality rates. Morbidity is also extremely high from these operations. And again, even when you look at the highest volume centers, you're talking about a major morbidity, so not just a UTI, but spinal cord ischemia, dialysis, MI, stroke. It's 39 to 50%. So the morbidity of these operations remains really high, and there hasn't been tremendous ability to reduce this into single-digit range. So the contra side to that is the endovascular therapy. The kind of endovascular therapy as a whole, as I'm sure so many of you in this room know, really got its start in the 60s and then progressed, including coronary angioplasty and then ballooned expandable stenting from the 60s to the 80s. When we talk about treating aneurysm disease, it wasn't until essentially 1990 that this really kind of was established. And Dr. Volodis was from Russia, who's thought to have actually done the first one, but because of the Cold War, really didn't get a lot of publication about it. And it was really Dr. Juan Perotti from Argentina who kind of created this operation, who really is well known for it and disseminated it. And then when you look at that kind of worldwide, starting in 1992, the technology just expanded. And so it allowed us to now not only treat an infrarenal aneurysm, but has progressed all the way to dissection, more complicated aneurysms, valvular disease. And as a result, what we found is that we can treat a huge number of patients who otherwise had no options. They were not candidates for open repair because so many of these patients have their aneurysms as a result of smoking and comorbid disease, which precludes them from a highly morbid operation. But I say rapid kind of with kind of tongue in cheek, because yes, it grew and yes, we've expanded, but remember that the EVAR kind of was created in essentially 1990. It wasn't until 2012 that we kind of really made a big advancement in terms of how we can treat it. So we were previously able to put single stent grafts in, but that basically precluded treatment anywhere where you have a branching vessel. And so from 1990 to 2012, there was lots of evolution of EVAR devices, but we still had no ability to treat anything near the renal vessels and the visceral segment in the arch. So we're really limited. So in 2012, the first device capable of treating branches was approved by the FDA. This is the ZFEN device. And I think it's important to note, this is still for infrarenal aneurysms. They're just those that are close to the renal vessels. And so they have holes or fenestrations created to allow blood flow to get to those areas. The important thing anytime we're talking about endovascular therapy is in order for it to be successful, you have to be able to seal into healthy tissue. And so that requires really at a minimum of 1.5 centimeters of healthy normal vessel. So that's kind of the distance we're requiring. But the ZFEN was a huge step forward for us kind of nationally. The kind of next step was a decade later. And so this actually was just approved last May. And this is the branch device that allows us to start treating pathology near the aortic arch. Right now it is approved for zone 2. So as you can see in this picture, that has a branch that goes up into the subclavian artery, but we're still treating aneurysms below that level. I will say we were kind of one of the largest enrollers for the clinical trials, and we're sites for both of them here at UW. And we actually use this device all the way into zone 0 right now, but that's still technically off label. So we've made progress. I would say rapid is probably very generous for what is actually happening. And that's, I think, a combination of challenges between regulation and the FDA and industry as well. And so despite these advances, there's a lot of areas that we still need newer technology and techniques for. And this is really all the areas that include the branching vessels. So the ascending aorta, the aortic arch, and then really anything thoracoabdominal. I will say, however, as I'm sure most of you know, surgeons are impatient human beings. And so kind of just continuing to wait for the FDA to approve things and industry to come across generally didn't go well because there were so many patients we technically, as of now, still are unable to treat. And so as a result, you have a lot of surgeons who have been trying to figure out how we treat these patients without just waiting. And I would say UW is arguably the most aggressive and advanced center in the country on that. In 2011, we became the first institution to have a FDA-approved, physician-sponsored investigational device exemption study to treat aneurysms in the area of branching diseases. And that was 2011. And today, there are now 16 centers in the country who have approval from the FDA to do this. The first IDE was my partner, Dr. Ben Starnes. Obviously, he is very well known for this, and his was doing modification of the grafts available, so EVARs and TVARs, to treat these juxtarenal aneurysms. And remember, this was before the ZFEN device was ever approved. So he was kind of ahead of the curve. I came out here and have joined him in this practice as well. And so this allows us to kind of take a device, unsheath it back table, and literally burn holes in the device, which are aligned with each patient's unique vessel anatomy. So every graft is unique. And then we resheath it and implant it in the patient. And we've done about 250 of these thus far since 2011 as part of the IDE. So again, this is the first in the country. This was joined very shortly thereafter by my partner, Dr. Matt Sweet, who I'm sure also many of you know. And he really took Dr. Starnes' IDE and then advanced it as well. And so this allowed us to treat thoracoabdominal disease. So now we could treat everything from the subclavian artery all the way down to the iliac vessels. The unique thing about this IDE is it actually gives us access to custom devices. And so we do a lot of complex planning, and then the devices are built for each patient's anatomy, which gives us a lot of flexibility for care. When I came out here in 2020, I joined Matt, and him and I have kind of really grown that practice collaboratively. And so, as I mentioned, we have these two IDEs. We're actually still the only center in the United States that has two of them, which is very exciting. And between the two of them, we have the ability now to treat patients with disease from zone 2 of the arch all the way through the iliacs, just with these two IDEs specifically. I think one of the really exciting things, though, is we're proud of what we're doing here, but really are the results translational. So what we joined in 2018 was the U.S. Aortic Research Consortium. And this is all centers in the United States, and you notice this is still only 10, but who have access to these custom branched and fenestrated devices. As you can see, it's a little bit of a desert out here. So our patient population comes from a very wide array of locations. I would say my kind of farthest location that I've treated in the last 3 years is a patient of mine from North Dakota, who continues to get her regular care out here. And so it's a big population area. There's a ton of need for it. But I think one of the most exciting things is we talked about the morbidity and mortality of treating these patients using open repair, which is between 15 and 30% essentially. And what we were able to find is treating thoracoabdominal aneurysms using this approach actually has achieved a 2.2% mortality rate. And this is the first 1,600 cases done around the United States. And so I think overall, kind of these two programs have really improved our ability to treat patients with cardiovascular disease with far lower morbidity and mortality than the open thoracoabdominal aneurysms, which still have an important role, but I think their role is becoming more focused to try to achieve more durable long-term outcomes. And when I talk about these numbers, I mean, looking at them, perioperative mortality, 2.2 from 20%, and 20 is the average of all centers. When we look at lower volume centers, it's closer to 30. And then major morbidity for these operations, it's still not zero. I mean, these are sick patient populations. And so when we talk about this major morbidity, again, this is not UTIs, this is spinal cord ischemia, MI, stroke, new dialysis, it's about 10%. But this is down from 50% to the historic open operation. But I would be remiss to say, we've solved the problem. These devices really do it for us. The device access alone is only a small part of why we've achieved this success in management of this patient population. For us here, I think what we've found, and we continue to find day after day, is that the team approach is why we are successful, because the care of these patients requires complete medical and surgical expertise in the entire aorta and really the cardiovascular system. One of the most kind of valuable things we've been able to look at is the medical optimization of these really sick patients. And this is in part because of collaboration with your team, as well as genetics and everyone else here at UW. But really, I mean, we are not experts in the optimal treatment of patients with aortopathy, and there's a lot of them. And I think we're learning more and more every day about how widespread aortopathy actually is. These also are patients who are sick and have extensive cardiopulmonary disease. And so taking care of that is really key to setting them up for success to manage their aneurysm before we even start. I think the other really key thing that can't be understated is the surgical collaboration in the sequence of events. When we talk about the whole cardiovascular system, these are patients who have disease in multiple places. So they have valve disease, they have coronary disease, they have ascending disease, they have arch disease, and they have thoracoabdominal disease. And I think trying to think about them in silos actually doesn't work well, but rather the collaboration allows us to kind of tackle it all in a thoughtful manner. And so when I talk about this, this is actually our patient population. So this was a study that Matt Sweet and I did, I think published about 2 years ago, and it looked at patients with a diagnosis in our system between 2009 and 2019 of a thoracoabdominal aneurysm. And this is imaging confirmed. So we actually looked through CTAs of all of these patients. And what we found is that just shy of 50% have diagnosed coronary artery disease, and 21% have diagnosed congestive heart failure. I say diagnosed for all of these things because, as we alluded to with the first patient, I think by definition, nearly all, maybe save some of the aortopathy patients, of the older folks who have aneurysmal disease have some degree of coronary disease. They tend to be a population who is underserved and not plugged into care. So I think if we were really taking a step back, the numbers are probably likely much higher. These are just patients who are treated for it already. Almost 40% also have COPD, and 6% had confirmed by genetic testing aortopathy. So Marfan syndrome, vascular EDS, Loeys-Dietz, or other mutations. Again, I think in today's day and age, this is going to be much higher. We were just looking at a study with one of my fellows, and I looked at my endovascular cases for the last 3 years, and almost 15% of patients have a diagnosis of an aortopathy. So I think these numbers are actually much higher. I think we are just much better today, even than we were in 2019 in terms of testing. The other thing that I think is really important looking at this population is a quarter of these patients did not present electively. So they were here with another problem, or they were symptomatic or ruptured. So a really sick patient population overall. I think the graph on the side is also very telling. We talk a lot about all the patients we operate on, but a very significant number are not operated on. And that is in part because of how sick they are in regards to their other disease processes. And so I think, this is a significant operation with morbidity. And so we have to be thoughtful, trying to put the patient through that who really has, less than a year life expectancy is, I think, not ethically a sound thing to do. And so this is kind of where we're saying, and you see there's a lot of patients, probably around 50%, who don't even get offered an operation. I think as our technology is changing, this number is going to decrease, but this is where we were as of 2019. So I think by definition, talking about this complex patient population, they're inherently high risk. Among the older patients, the traditional cardiovascular risk factors are really extensive. Coronary artery disease, COPD, kidney disease, smoking, they kind of all run in the same vein. And then among the young, and there are a not insignificant number of them, there's very high rates of genetic aortopathy and also drug use, particularly methamphetamines in this area. Cocaine is something we also talk about, but I think in the population kind of that we see, we do see a high rate of methamphetamine use, which with these folks coming in with dissections right off the bat. And I think one of the things that's important, and I think you all know probably better than any, but not all folks in the community recognize, is when we talk about doing an endovascular repair on these aneurysms, it's not an EVAR. These are much more morbid, longer operations. I think Dr. Sweet and I are very high volume surgeons. We do them very quickly. It's a well-oiled machine, but even so, the kind of fast operations take about 4 hours. So if you're looking at a really complex version, this could be a 6 or 8 hour operation. So these are big operations for these folks, albeit percutaneous and with minimal blood loss often. The other, I think, risk factors which are important to recognize that are very specific to our populations here are the high rate of concomitant disease in the rest of the aorta, as well as the cardiovascular system. So in our population, about a quarter of these are done for folks with dissections. Most of these have type A dissections that then were lost to follow-up or got replugged in when they grew, which I think happens a lot more than we really recognize, just because loss to follow-up is such a big challenge there. There's also high rates of concomitant valve disease. I have a lot of folks who already have TAVRs in who I'm seeing, or who are picked up during that workup, as well as coronary artery disease. This is also quite a frail population. And I think one of the challenges that's not studied enough is the socioeconomic status of these folks. When you're looking at folks who, often have quite limited access to medical care and smoking, in our population, they tend to be very rural, often with limited access to medical care. So there's a lot of challenges, obviously, to managing this patient population. And I think that really led to the development of the MTAP program. An MTAP program here at UW is the Multidisciplinary Thoracic Aortic Program. This was developed, honestly, it was kind of the brainchild of Matt Sweet and Chris Burke, who I joked with, they could have come up with a more catchy name, but here we are, it's MTAP. But what they kind of were starting to look at these patients is their kind of unilateral siloed approach of vascular cardiac surgery was clearly insufficient to achieve really good patient outcomes, especially as we're trying to propel technology forward. And they, I think, really astutely recognized that all areas of expertise, medical, surgical, and genetics, were really necessary for complete decision-making. And that more than one opinion and more than one person's experience was far more valuable than a single. So in 2020, the Multidisciplinary Aortic Program was launched. And this is kind of as we stand today. And we meet every week on Thursdays at 5 o'clock. It's a Zoom meeting at this point. And we do case review, care planning, and we also are kind of really now also promoting research priorities. Obviously, some of these faces. From a cardiology side, it's really led by Catherine and Yoni, who have been great partners in this. Cardiac surgery, we work with all the cardiac surgeons, but Chris Burke and Scott Giroux kind of really lead off the aortic side of the operating. And then Matt Sweet and I kind of lead off the vascular side, but we have additional partners. Kirsten Dancy, Matt Smith are below. And then Peter Byers kind of helps lead it from a genetic side of it. So it's a really kind of collaborative group that's been fantastic and continues to expand. I think the exciting thing is we often have practitioners who are not in this group that bring their patients to discuss, which is, I think, always interesting and exciting. And so how does it work? Well, as I mentioned, we meet every week on Thursdays, and it's kind of all specialties are here. There are outside physicians that come in. We've had, team docs from UW sports teams come in to talk about their patients. So it is kind of an open forum. And we talk about anyone who has potentially operative arch pathology or thoracoabdominal aneurysms, or who we have concern for aortopathy with. I would say there are also folks who come in with questions about activity and how we should go forward in screening. And so it's a really kind of open forum for this discussion. The content is very focused clinically because I think that's most relevant for decision-making for all comers. And it's important to sustain engagement from all of the groups rather than it just being led by, vascular surgery or cardiac surgery or cardiology. I think the collaborative approach is really the key. And so trying to understand this. So what happened as a result? So this was kind of the brainchild in 2019. And these are just Matt Sweet and my aortic case volume per year. And what you see is that 2020, where it's just circled, was kind of the first year of it, and we've just had nothing but an incline. And I think really important to this is it's not just been the endovascular therapy. It's also been an increase in our open aortic volume over this time. 2023 is obviously not over. I'm also very pregnant and not doing as much operating. But I do think by the time we finish this year, we'll be at least level to last year. So what you see is, at least even just for two vascular surgeons, this collaboration has actually just been nothing but productive in kind of building the program. But I think from a systems point of view, it's not just been the two of us in our cases. It's actually been a tremendous incline across the system for aortic volume. And I would say this doesn't even include all the valve cases that you guys are doing. So this is just the open aortic and endovascular aortic operations. And so you see it continues to go up. Last year, between cardiac and vascular surgery, there was 350 aortic procedures done here at Montlake, which is huge. I mean, these are some of the biggest numbers in the country for actually like a very small number of surgeons. And so it's exciting. And I think it shows from a case volume perspective, there's a ton of benefit to collaboration. But I think beyond just the case numbers and RVUs, frankly, I think there's more value than what we talk about. And I think kind of the first thing we talk about is our improved options for treatment. And again, this is kind of just since the development and kind of push forward of MTAP as a whole. We've been able to get involved with clinical trials for new devices. TAMBI is going to be likely the first branch device available on the market to treat the visceral aorta. We were a trial site for that. TBE, as I alluded, was just approved last year for treatment of the subclavian. We were the largest enroller for zone 0 and 1. And Endospan is a very similar device. And so we've been in leading trial sites for these devices. One of the things that's upcoming that we're really excited about is the ARISE trial. And this is coming to UW, and again, is a collaborative trial to manage the ascending aorta as well. So there's a huge need for this and a role for this. So this is coming. And then just this year, we received approval from the FDA and now UW IRB to actually enroll patients with aortopathy into these branched and fenestrated cases. That has historically been a contraindication for repair, which has left a very large population, I'm sure who many of you know, who are too sick to get an open thoraco without a treatment option. So this I think is a huge step forward. And honestly, it's an area of need and lack of understanding that we're excited to grow. I think the value of MTAP is, this seems obvious, but these trials require multidisciplinary and multi-specialty collaboration. This should be easy and obvious, but I will say this is actually a huge barrier at many, many hospitals nationwide because of ego and turf battles. And so collaboration, I would say, in particular between cardiac surgery and vascular elsewhere, is challenging. I feel tremendously fortunate that that is not at all a case here. We are a very close-knit group, and I think that has been one of the keys to the success of us getting these trials and being leading enrollers. And frankly, it's benefited everyone. So beyond clinical trials, I think the other thing that's been really excited, and again, we're just talking about 3 years here, is that we've rapidly evolved our treatment. And an example of this is the aortic arch. So up until 2022, folks who had, for example, an open ascending would be treated with a transposition and then a redo arch and a frozen elephant trunk, so a TVAR, and then a TVAR extension down to the celiac artery. That has evolved in just a little over a year, and now they get their zone 2 arch, but this is followed by a TBE, so one of those new devices. And we do it while they're in the hospital, usually. There's a lot of benefits. This has saved us, even though our operative numbers are increasing. This has actually eliminated an entire operation for these patients. And the complications that are associated with it, which are not high rates of complications, but they're not nothing. Once again, I mean, anytime you're working in the neck with these folks, particularly when they have not had their arch fixed. And so many of them have concomitant valve disease. And so trying to do their transposition before you've addressed that is not insignificant. But also it allows us to stage it. And that reduces our risk for spinal cord ischemia when we do this. So this, again, in just 3 years has dramatically changed our treatment algorithm. Beyond that, and I think probably at least as important, is our management of the complete aorta. I think the collaborative approach to the timing of these operations and staging is super important. because of how extensive the disease process is. And so how and when we manage their valve disease or their coronary artery disease, I think is a really important question that I think just looking in the chart or just referring to a patient to a cardiologist doesn't necessarily do the same thing as having an open discussion when you're talking about patients who are this complicated. And I mean, to be frank, I usually do not know the answer. And how severe their coronary artery disease, is this something we should do ahead of or before? How do you guys approach it when you have aneurysmal disease or dissection in all of these places? And then, as we talked about in that case example I started with today, is what do we do when patients have their whole aorta that's diseased? Do we start at the top? Do we start at the bottom? How do we select that? We know we can't do the whole thing at once. It's far too morbid. They don't survive that. And frankly, even if they did, they would be paralyzed because you would take out so many collaterals to the spinal cord that it would not have any meaningful result. And so trying to just make these decisions is actually really tough. And so being able to have this conversation with all parties involved, I think, is really beneficial. In addition, allowing us to stage like this has reduced the magnitude of all of these operations, and it gives patients time to recover between stages and to come in their best possible shape without too much delay. By staging it, this also serves as a stress test of sorts. And for those who kind of can't survive the big final operation, and for some of those, that's an open thoraco. We know that up front. And so we're not submitting them to that where they might not have survived. Beyond the surgical approach, I think there's also been tremendous benefit in kind of medical standardization for these patients. I think one of the things, and again, this is a work in progress, this changed in April of this year. We changed our policy for genetic testing, and this was kind of in discussion with all of the groups at MTAP. Historically, it was kind of physician driven. So if you had a suspicion for an aortopathy, you would just send the test, or maybe you would refer to genetics and then just kind of see what happened. What we do now is actually far more aggressive. As of April, we decided to start offering testing to all patients who were under the age of 70 who had aortic disease. And this is because we were starting to see a lot of older folks who we treated, and then we went in and realized these tissues are really delicate. And so we would screen them after and started seeing a lot of positives, more surprisingly. So now we offer screening to all patients under the age of 70 and anyone with a first-degree family member. I would say, additionally, if we're in the operating room and someone has really delicate tissues, we also have a really low threshold to do this. The other thing we've done is historically this had to be an outpatient thing that was ordered by genetics. So now we can order it ourselves inpatient. The blood is drawn, and so it kind of takes out one of the large barriers to care in that population. And then to try to minimize the burden on the genetics team, which is a very small team, now I refer patients to them for the full kind of discussion when they're positive, or we'll talk about patients who we're still concerned about at MTAP to try to allow it to be a more efficient practice for them. The other things that are kind of in process are the development of patient handouts and unified messaging. One of the things we've been still working on, and there's been lots of discussion at, is kind of physical activity and exercise guidelines. It's like a common patient question I'm sure you all see all the time is, well, doc, I have, an aneurysm, I have a valve disease. I've been told I shouldn't work, or I've been told I should no longer exercise, and trying to come up with a clear algorithm and frankly, a handout that's going to be able to be created from all of the specialties with everyone's input. Additionally, I think one of the really big things that has come up is kind of surveillance and imaging protocols for patients with a genetic diagnosis, but no pathology yet. These patients still clearly need to be followed because they have high risk, but trying to figure out where they should be followed, how frequently they should be followed. Should they get CAT scans? Should they get MRI? Should they get duplex? I think the development of this has been really helpful for us and kind of starting to have a streamlined protocol. And again, I think all of the purpose of this is to avoid patients getting dropped, because we know when they come in symptomatic, their outcomes are much worse. So trying to do it prophylactically or ahead of time, I think without question results in improved outcomes. And then finally, and honestly, arguably the most importantly, I think guidance for medication management is really key. This includes blood pressure goals, the type of medication. So really changing to, it's obvious to you all, but I will say to our colleagues, it was not historically obvious what types of agents we should be treating these aortopathy patients with, or patients with dissection. What are the most valuable? And so kind of that guidance, I think, has educated all of us, but also I think leads to improved outcomes and collaboration. The avoidance of fluoroquinolones obviously is no surprise, but is another kind of key thing that now ends up not only in the notes when they see the cardiology team here, but also our notes very frequently. And I would say this is super important because when they're coming in from other cardiologists in North Dakota or Alaska, this actually often is not the case. And so it allows us to also ensure that they're on the optimal medical regimens. So finally, I think one of the things I talked a lot about in the challenge is the loss to follow-up. When you look at patients who have had aortic treatment nationwide, it's about 50% of folks who are lost. And this is a really big deal because what we see over time is more than 20% of patients who have had aortic surgery need additional surgeries down the road. And that's because this is a progressive chronic disease. And so getting lost to follow-up, it's really increases the risk of rupture and complications long-term. I think type A dissections are arguably the poster child for this. I talk to all my fellows and trainees and I say, I see them all in the hospital after they have had, once they're extubated and survive. And I kind of go through, you have an aortic dissection. This is what this means. This is what this looks for. You and I are going to become friends. This just becomes part of your medical history. I would say about 80% of the time, the patients do not remember that conversation. And so we, before they leave, set them up with a CT scan and another appointment with vascular surgery, in addition to their obvious follow-up with cardiology and their cardiac surgeons. And when they come back to my office, we then basically have the same conversation. And it is remarkable how many of them do not remember what was happening in the hospital. And I think it is truly just almost like a post-traumatic stress situation. It's such a life-altering event that the small things, the fact that, no, you don't need surgery down the rest of your aorta right now, but it's something that has to be followed, and here's why, is a really important conversation. If you look at other centers around the country, including wonderful academic centers where I've been before this, there has not been a clear protocol in place, and I think it's very haphazard. The cardiac surgeons do their operation, they get them through the surgery, they save their life. Cardiology comes in and kind of gets them teed up. But then the rest of their aorta is often lost, or sometimes they're lost to follow-up. They're just so happy they are alive that they forget kind of the bigger picture of this. And so I think kind of the system that we've developed here is really changing it, and it has had a huge improvement in patient care. And so now when they come in, certainly their life-altering event takes priority. But then once kind of they get back in the ICU and they settle out, we actually see all of these patients in-house. And we scan them before they leave so we know what we're working with. It also helps us to know who's going to be high risk. Who do we need to get on the books to start thinking about extending their treatment now versus who are we just going to plug in for long-term follow-up. And then they're established with appointments before they leave for complete aortic surveillance and new medication management. And I think this is really important for the kind of long-term outcomes of these patients. So finally, I think the really important thing of MTAP, which is a concept that is increasingly being discussed in the surgical literature. I imagine it's the same for cardiology. It's the kind of concept of rescue and failure to rescue. And I think one of the things that MTAP has allowed us to do is improve our ability to rescue. We talked about the fact that major morbidity is really unavoidable after open AAA, and it hasn't changed, and it's as high as 50%. It's also 10 to 15% after endovascular repair. So there's still significant morbidity to it. That being said, morbidity does not have to be the end all. I think our ability to rescue allows these patients to make it through and actually return to good functional status, even if they have this major complication or are in the 10 to 15%. And so I think some of the changes that have come, again, even just since I've been here in the last 4 years, have come from the discussions that have happened with our collaborators and the intensivists and your teams in cardiology. And I think ECHO has been the game changer, in my personal opinion. When I started, we were not routinely echoing all of these people pre-op, nor was I sending them to medicine consult service or anything like that. We're just kind of going through their history and understanding their functional status and kind of making a judgment on that. That has shifted. So now every single one of these patients gets an echo, and I will tell you, I'm surprised. Every few months, I have a patient who has no diagnosis, and then we echo them, and we found out, oh, their EF is actually 35%, and they just had no idea. Or they actually have wall motion abnormalities that nobody knew about, or they have valve disease that wasn't diagnosed. And so we do see this, and it definitely affects our decision to treat. I think as as important is the use of echo intraoperatively. Historically, these patients do not, the cardiac anesthesia group here is amazing. Not all of them have echoes down their esophagus during the operations. They're in our way sometimes as we're trying to work, and it's not necessary. But I think our understanding of the value of it and really aggressively using it, particularly for any hemodynamic changes intraoperatively, has been a game changer. We also use it post-op when someone's hypotensive, just to look at volume status. It, I think, allows us to pick up hypovolemia better than sometimes we do otherwise, because these patients do have hemodynamic lability. There's no question about it. And hemodynamic lability is a huge deal because hypotension, even in the setting with pressors that is supporting them back up, actually really increases the risk of spinal cord ischemia, which is a devastating consequence. So the use of echo, I think, has been incredibly important in improving our care. I can tell you just in the last year, we've identified new MIs, a spontaneous mitral rupture that one of your colleagues treated and immediately fixed my patient's hemodynamic instability, new dissections from the devices themselves, CHF exacerbations, and frankly, just fluid management, whether we need to resuscitate these patients more or less. So I think it's been an incredible adjunct to this patient population care. So back to our case. So I'll show you his scan again, and you can kind of really see, obviously his root is huge, as you'll see here. It gets quite large. His aorta looks okay in the thoracic aorta, and then you're going down and you're going to see his EVAR coming up, which is obviously not opposed. He's very robust in the visceral segment. His EVAR is just kind of floating there with clear flow coming down and around it. And he has endoleak in his sac as well, huge iliac aneurysms bilaterally. So this is his CT. So what do we have? Well, we have the challenges of his synchronous aneurysms in the ascending and a large thoraco. 8.6 is quite large. I think the largest we've done in the last 3 years is 14. But I mean, 8.6 is big. The risk of rupture is not insignificant. He also has a very complex cardiopulmonary comorbidities, even if he doesn't have the diagnosis. His father had an early cardiac death at 42, so pretty young, even though he doesn't have a diagnosis. And he has pretty poor functional status. So I'd say at 58, only being able to walk a block or two, presumed to be because of COPD, is kind of a red flag for us. And so the question for all of this is, well, what do we do? What's the timing of this treatment? How do we work him up? How do we maximize it in a timely fashion? Because 8.6 centimeters is big. The risk of rupture is not insignificant. And so how did we approach this? Well, as all of these patients, even though he's fairly urgent, I saw him on a Tuesday, we chatted about him at MTAP on Thursday. And there was that kind of expedited our ability to kind of manage all of these things, because if I had to refer him to cardiac surgery, referred him to genetics, referred him to cardiology, it would have been weeks before we could even try to come up with a plan. And so we brought him to MTAP. Clearly, there's a concern for aortopathy here. I mean, he's young. He's only 58 to have 2 very large synchronous aneurysms. He also has an early death in his father, which I think we see a lot of. Patients usually just assume it's a heart attack. That's what they say. But I think the reality is we often don't know. That may be the case for a lot of them, but it may be that they had an aneurysm rupture that nobody knew about and they died the same way. It's also often a sudden death. So he was presumed to have aortopathy. That being said, clearly he is not a candidate for an open thoraco repair due to his functional status and other cardiopulmonary diseases. But trying to wait for him to confirm this for 6 to 8 weeks before we even begin to address these aneurysms, which is how long the genetic testing typically takes, is problematic, because remember, this is going to be done over multiple stages. So that's really going to delay and increase his risk of rupture. So it's a challenging situation. So ultimately, the decision was made to get an echo on him, which frankly looked fine. It didn't have any major abnormalities. He did get genetic testing, understanding it wasn't going to change how we approached him. And then his medication regimen was slightly altered. So he was starting on an ARB and he was on a beta blocker already, which was continued. He then began the process, and the plan was to do a staged repair essentially over 6 months. Because of the size of his infrarenal aneurysm and the fact that he did have a healthy-ish sealing zone in his thoracic aorta, meaning we can treat his aneurysm and actually theoretically fix the bottom, the decision was made to start with that. Oftentimes that's not possible because they have no sealing zone to seal that stent into. So we have to start at the top regardless of where the size is. But for this patient, that was not the case. So the decision was made to start with the branch repair of his thoracoabdominal aneurysm, and that was done within the week, followed by an open zone 2 arch, and then finally completing that repair in the mid-segment, which means you're sealing into surgical graft proximally and a TVAR device distally. And so that was going to be the plan for him. So how did it go? So I took him to the OR for a 4-branched repair, which fortunately we have off the shelf, so we don't have to wait for manufacturer time. So he got a TVAR, which is what you see on the side, followed by the branch device. And let me see if my work. So these are our branches right here. And so essentially what we do is we line them up with each of the visceral vessels, and then we cannulate them. We used to do this a lot with arm access. It's now almost exclusively through the groin using steerable sheaths. And so he got all of that done. He did really well. You see his completion angio on the side of this. The case went quite well. These can be really tough cases. He was one that was done in 4 hours, no big surprises. So we were all high-fiving and feeling great about ourselves, got him through the first part. He's got no endo leak. Awesome. So as he's waking up, hemodynamically stable, but ectopy is noted. The anesthesia team kind of had suspicion for concerns in him. This was the case that they echoed him before we started the case. They intermittently echoed him during the case, and then they echoed him, at the end of the case. What they saw at the end of the case when he had ectopy was a very bad dissection, actually. And here you can see it on the CAT scan. And his dissection went all the way to his root. And frankly, by the time he got to the OR, included his coronaries. So I'll play this through again because I think it is actually an example of a really bad dissection that honestly, if he had dissected in the community or we were unaware of this, this is one that potentially would not have been salvageable. Sorry, let me see if I can get this back to the beginning. And so when we look at it, it involves his subclavian and it goes very proximal. So this was identified in the OR. He literally stayed intubated and went directly to the scanner. And you can see what's particularly interesting about this from a surgical perspective for me is that I did not balloon the top of his TVAR because I was concerned for aortopathy. And so that was just purely from the placement of a TVAR, which shows that this is probably a very aggressive aortopathy that we're dealing with. Because we do TVARs in aortopathy patients, you worry about them, but generally they do okay. And so to get it even without balloon dilation definitely sends up some red flags. So he went from the table in OR 15 directly down to the scanner. While he was being transferred down to the scanner, I walked right next door to OR 16 where Dr. Burke was finishing a case. Dr. Burke already knew this patient and was well aware of him and said, okay, bring him back and let's see how he does. The good news is at this point, this guy was hemodynamically stable despite this. He was just having some ectopy. And so what happened? So he went to the CT scanner. He then went right back to the OR and he underwent a zone 1 arch and then ultimately a cabbage ×2. I think what's really interesting in this is the decision. And again, this was collaboration. So he's a young guy. He certainly kind of historically people would do ascending arches. Now that's progressed to hemi arches. And the reason why that matters so much is because this guy clearly is going to need the rest of his aorta fixed. And so if you don't address at least one of those head vessels up front, it really limits his treatment options. And so, you know, he's high risk for spinal cord ischemia because he's just had a huge portion of his aortic coverage. So you know, Chris Burke and I had a conversation about it and we decided, you know, if he can tolerate it, let's at least get one head vessel bypass. That way we have one vessel that we know we have. So when we come back, it makes our life a little easier and give him long-term durability with his head being fed by more than just one vessel. And so he was able to be done. It was an incredibly difficult operation. His tissues were extremely friable. As I mentioned, his dissection went all the way down to the coronaries just by the time he went from OR table to CT scanner and back. But I think much to the tribute of Dr. Burke's skill and collaboration in the ICU and cardiology and all the management, he actually did really well. He shockingly had no spinal cord ischemia injury, which is what we were very concerned about. Anytime you make someone who has fresh aortic coverage and this extensive coverage cold and put them under hypothermic arrest. But he did not. He did great. He got a lumbar drain as soon as he got to the ICU to try to prevent that. And ultimately, he actually was discharged to home. He didn't even have to go to rehab, which is surprising, to say the least. But that wasn't it. So remember, he still has dissection in his aorta now he has that dissection. So he's getting some flow back into his aneurysm distally. And so ultimately we let him recover from this for a couple of months. His blood pressure management was a challenge, but with collaboration was able to be accomplished. And so brought him back to finish his aorta. And so this is a TBE device, which you can see here. And so I did a carotid subclavian bypass. His tissues were super delicate, so we used felt. And then I did a zone 1 thoracic branch repair via the radial artery and coiled that subclavian. What you see in these pictures, this is the bypass graft right here. This artery was dissected, so it was a tough operation, but nonetheless was able to be done. And interestingly, during that time, his genetic testing came back positive for Louis Dietz here, so not surprising. So it kind of explains his whole process. So where is he today? So this gentleman, this is his scan that's most recent. You can see kind of his whole aorta is repaired. His aneurysm is actually regressing, which is very exciting for us. But he has done actually extremely well. There's his branches you can see right there, kind of going to all his visceral segments with good seal. He does have a little bit of an endo leak there. It's one of the challenges with connective tissue patients, but he's not growing, so he's going to continue to have it watched. He's 1 year out now. He's returned back to his baseline status. He's optimally managed. An interesting twist to this story is about 3 months ago when I spoke to him, his son had just presented to a hospital in Texas with a dissection. He was plugged in and just had not gotten his genetic testing results back yet when this happened. And so the good news is he was in a small hospital in Texas and then as a result was able to be referred to one of the major centers who's used to dealing with aortopathy patients. And he is now in the process of getting a complete aortic replacement. So I think this is a great example of kind of what we're working with. And so despite a really challenging course, this patient actually had an excellent final result. This is likely due to the anticipated challenges and a rapid management of his complications. Cardiac anesthesia really worked off cardiology guidance, and intraoperative echo was critical. I think cardiac surgery was aware of his case and was prepared to take him directly. And then he had really excellent post-op care by the whole team. The patient and his family remain super grateful. And interestingly, so does his, private practice cardiologist from a small town up on the border of Canada. We still kind of are involved, and he has become one of our higher referring providers as a result. So I'll kind of conclude here. I think his case is a really interesting example, but complex aortic disease has really changed in the last 50 years. But that being said, the limited endovascular devices remain a challenge. And outside of selected centers like ours, it's really the Wild West. People are just kind of doing whatever they can think of. Open aortic surgery, which I didn't talk about as much, is still present and I think has increased, and it's definitely increased at our institution as we've developed this collaboration. And I think its role is not going away, especially as the genetic background of these conditions is increasing and our understanding is changing. We're lucky to be a high volume center that has the unique ability to treat these patients, which has unquestionably improved results. I think that multidisciplinary approach and collaboration has been the key. It's allowed us the introduction of novel devices, and now we can treat the entire aorta. I say that delicately. I think the final frontier is being able to do valve to iliacs, which is going to come, I think, but that's still new, but it's coming right now. I think even last night we talked about a patient who our limiting factor is currently their CABG. Their bypass graft is coming out, so that precludes us landing proximally. So there are still challenges, but I think they will be overcome as we expand this technology. We have improved treatment for patients with aortopathy. Medication management is really not well understood in the community the way it is with your whole team here. And we have open and endo options now for these patients, which is exciting. MTAP has allowed improved follow-up and perhaps most importantly, unified messaging and comprehensive care for the full system, which I think is really the kind of key to this. So I'll stop there. Thank you very much for the opportunity. I realize because of Zoom, we actually don't all meet in person very frequently. So I don't have a picture with all of the MTAP crew, but certainly Yoni, Catherine, Peter, David, and so many of you guys who have helped in the care of these patients. We are really grateful, and I appreciate the opportunity to speak today.
Thanks so much, Sarah. Let's start with some questions for Reed.
That was an excellent talk. So you presented a case with the TGF-beta mutation. I guess my question is, what's the hit rate when you're doing genetic testing, and what are some of the other genes that you pick up? And then kind of expanding on that, are you picking up a lot of like variants of unknown significance? Because that's one of the challenges when you're doing aggressive genetic testing.
Yeah, no, it's a really great question. And actually one that nobody knows the answer to, which is part of the reason we changed our policy to now universally test everyone, because it's hard to know the prevalence when it's sporadic. So what we are actually going to do next April is summarize all of those results. So we're going to know in patients over 70, what's the hit rate, in patients under 70, what's the hit rate, and what's the distribution. I think one of the really interesting things is, so the panel is, I think, about 40 genes at this point. A lot of them are variants of unknown significance. And so we used to be like, oh, you know, what does this mean? Peter Byers will weigh in. But I will say, as there's a patient we were going to talk about last night, but ran out of time, who had 2 variants of unknown significance. And so we thought, you know, this is probably nothing. Well, he knew that. I've also done his complete aorta with collaboration with cardiac surgery. He's fixed, doing fine. 2 of his siblings now both have the same confirmed genetic diagnosis with variants of unknown significance. So clearly there is significance to it. Another example I can think of is a Notch1 mutation. We see them, we kind of thought nothing, but now we have a collection of patients with this. So I think what we're learning every day is that these are not so insignificant, I think a lot of them. I think it'll be really exciting in April once we have our 1-year data from this, where we can kind of put out and actually see what the result of that is.
I wanted to check, do we have any online questions, Doan? And then while you're looking, Janonso, do you want to ask a quick question? Yeah. We have maybe time for 1 or 2 more.
Okay, so quick question. Thank you for your talk. It was very good. I really appreciate the impact that endovascular repair has had, especially on a lot of our sickest cardiology patients. What's the process of physician modification for the EVAR and TVAR devices? If that's a quick question.
Yeah, no, that's a great question. So the key to that thing, and the hard part about it, which is why it's not super widespread, is planning. It's about an hour of planning. So we take the CT scan, I put it into Terra Recon. I don't know if you guys use the same technology. I know they do cardiology work as well. Straighten the aorta out, and I do all kinds of measurements. So I measure the length of the seal zone, the size of their vessels, kind of where they are in terms of coming off angulation and arc lengths on the aorta. So it's a little bit of physics, frankly. And so I spend about an hour designing it on there. And then I choose my graph. So I'll choose my EVAR or my TVAR device, and then bring it back table. And what I do is I use electric cautery to actually burn the hole in the graph. And it's a little bit of kind of timing, because you don't want to put the hole through a strut. So you have to kind of orient your graph and, you know, a little bit like that. And then put a radiopaque marker around the fenestration and suture it in. That allows us to see it on fluoro. And it also reinforces it and strengthens it so it doesn't tear. And then we resheath it and bring it into the patient to shoot an angio to allow alignment, which is honestly the critical step, because if you're misaligned and you cover the patient's visceral vessel, the patient's dead. So then we put it in, and then we use a variety of steerable sheaths, wires, catheters, cannulate, and then ICAST or VPX stents to do it.
Thanks. Online questions.
So we have a question from Lee Eschroeder. Have you considered an element of psychological or palliative care professionals in MTAP for these patients with prior dissection and underlying condition predisposing them to more in the future and living at the margins of our current surgical techniques? I imagine the psychological hurdles are significant.
Yeah, that's a great point. We've talked about it. We need it. There's no question. Palliative care we get involved with. We had a patient recently who's a young gentleman who not only has vascular EDS, but Lewy Dietz, who has been treated to a celiac and then degenerated. And frankly, the double mutation had not been operated on before. And there was really significant concern in the group that we couldn't get him off the table doing him because of the combined mutations, and kind of chatted around the country with folks, again, who hadn't either done it. And talked about actually doing palliative referral to him. His son had the same 2 mutations, so he elected to go forward fortunately he survived. But yes, palliative care has a huge role, especially with the fact that about half these patients don't get treated. I think psychology and psychiatry would be a great addition. And it's definitely something we should look into for the future because there's no doubt about it.
So very quick final questions. Did we have one more online, Dawn?
From Dr. David Linker, in retrospect, is there a different way you would have managed this patient? Also, it looked like the ascending aorta on the CT was enlarged. Was it? And if so, was the detected preoperatively?
Yeah, so he had that 5.6 root and his ascending was enlarged, which is, why we discussed it at MTAP. It's a hard answer. I don't know the answer if I would do it differently. I think in retrospect, clearly he needed his ascending protected. So maybe we would do his zone 2 arch to start with and then do the bottom. It's a tricky thing because recovering from an open arch is not nothing. So I think that might have been a different change, but I don't know.
And last quick question from Jim.
We should probably introduce you
Yeah.
to a palliative care specialist. And I think psychology is coming, right? So I've heard some thoughts that perhaps
Sounds like an area where we need to expand our resources for
Yes.
supporting these patients. Sarah, thanks so much
Yeah.
for joining us this morning.
Thanks so much for
Thanks
having
everybody
me.
for